Our guest panelist tonight is Dr. Meagan Grega. She is board certified in both family medicine and lifestyle medicine, and you can see her little blurb up there. Mine, it's been covered up by my people here. Let's get rid of that. There we go. And co-founder and chief medical officer of the Kellen Foundation. Dr. Grega is also the conference chair for this year's annual conference of the American College of Lifestyle Medicine. So we're so excited to have her here. Thank you so much for joining us, Meagan. You want to make your appearance? And you can unmute your video there. And she's sitting in the mountain somewhere.
Thanks, Ted.
Yeah, it's good to see. Where are you? What mountains are those?
Those are actually the mountains that my niece is working at in Yosemite National Park. So I'm in Pennsylvania, but I'm enjoying vicariously Yosemite.
Excellent, excellent. And Dr. Breakey, who is our regular partner in crime at these events, is also board certified in family medicine and lifestyle medicine. And he's, as you can see, been working in Ann Arbor for 36 years. And he's the medical director for IHA's William J. Folletti Institute of Lifestyle Medicine. So we're so excited to have Dr. Breakey here. And Melissa Sundermann, who please unmute your video there. She is board certified in internal medicine and lifestyle medicine and works with Dr. Breakey at IHA and gives great lectures on getting outdoors and exercising. So thank you for joining us, Melissa. And now I'd like to just introduce Dr. Graff. Let's see here, I gotta push another button. There we go. Kerry Graff. There she is. She's board certified in family and lifestyle medicine and serves as the lead lifestyle medicine physician for Rochester Regional Health in Western New York, which is right here in Rochester, New York, and works to integrate lifestyle medicine throughout this large healthcare system. And she's the co-author of the 4-Leaf Guide to Vibrant Health, using the power of food to heal ourselves and our planet. And Dr. Susan Friedman is our case wrangler and adds legitimacy to pretty much everything I do. She's board certified in geriatrics, internal medicine, and lifestyle medicine, and professor of medicine at the University of Rochester School of Medicine. Also the lead author on a white paper of healthy aging, published by the American Geriatric Society. Very excited to have Dr. Friedman in the background here. She's not going to be making her appearance, but she, unless I desperately need her. So hopefully that won't happen. So this is the case, spotting the red flags when things are not as they appear. Case presenter will be Dr. Kerry Graff, and I will stop sharing. And Dr. Graff, take over, please.
Well, thanks everybody for joining us. Hopefully you will enjoy the case today. This is not aligned.
And I will talk while you're getting that share going. If people want to put questions or comments in the chat, for one thing, where you're located is always fun. Like if you're in Oklahoma or something, you can type that in the chat. And if you have some questions or comments, you can put those in the chat as well. This is a regular Zoom meeting. It's not a webinar. So if you want to appear, you can, and we'll encourage that at the end. So take it away, Kerry.
Okay. So this was a case I picked very shortly after Ted asked if I had an interesting case to present. And I just seen this patient. I was like, I have no idea what the heck I'm doing with this one. This will be a really interesting case. And we'll see how it unfolds between when he asked me to and tonight. So it was a little bit of a not knowing kind of how this was going to turn out when I picked this one. So I hope that you have some get some good points from it tonight. So patient is Rebecca. Obviously that's a fictional name. 38-year-old morbidly obese female, referred from bariatric surgery for a lifestyle medicine consultation after being determined to be ineligible for gastric bypass surgery. She specifically states that losing weight would help her be a lot healthier. Medical conditions include morbid obesity. She has had chronic migraines since 2004. And the history is that she had really mild, rare migraines as a teen. Almost as soon as she started working as a nurse in the ICU, she started getting really pretty severe and continuous migraines. And she actually didn't end up working very long as an ICU nurse at all because she became completely unable to work. Her migraines are now daily, but they're no longer continuous. So she'll have periods of time where she doesn't feel the headache, but she still has headaches every single day with the current medical regimen she has. And in addition to the medical regimen, which you're going to see in a minute, she was status post an occipital nerve stimulator that had to be removed due to it getting infected. So she's had a pretty substantial treatment for chronic migraines. She also reports anxiety, depression, OCD, and PTSD. She was started on Risperdal 12 years ago postpartum, but specifically denied that she ever had any psychotic symptoms, and she denied having a history of bipolar. She wasn't exactly clear why she was on that medication, but denied any psychosis. History of anorexia nervosa as a teen, hyperlipidemia, and continued list, reflux, asthma, kidney stones. She has mixed central and obstructive sleep apnea and uses an ASV. I actually didn't know what that was and had to look it up. So for those of you who also are not in the know on this one, it's an adaptive seroventilation, and it customizes the air pressure to stabilize an airway. It's a lot more comfortable than a CPAP, and CPAP doesn't help for central sleep apnea. The sleep folks in their notes said that they thought her central sleep apnea was secondary to her narcotic use. She's had 2 episodes of DVTs, both were from PICC lines. History of a cardiac arrest from a migrated Mediport problem. I don't know the details on this, and Ted says that that might not be exactly right, but that's what the patient told me, and that's actually what's in her chart. So how this migrated and what exactly happened, I don't know, but she had a cardiac arrest. And she's got osteoarthritis of her back, but various other joints bother her as well. Her medication list is extensive. MS Contin, 15 milligrams 3 times a day for migraines. Magox, 400 milligrams daily for migraines. Hydroxyzine, 50 milligrams 4 times a day for anxiety, and she uses that most days 3 or 4 times. It's a PRN, but she uses it pretty regularly. Lamictal, 100 milligrams twice daily as an adjunct medication for depression. Duloxetine, 60 milligrams daily for depression and anxiety. Ondansetron, 8 milligrams TID PRN for nausea from migraines. Risperdal, 1 milligram BID that had just been reduced from TID for psych reasons, a little bit unclear. Abilify, 20 milligrams daily for depression. Chlorthalidone, 20 milligrams daily for blood pressure. Famotidine, 20 milligrams twice a day for reflux. Pantoprazole, 40 milligrams BID for GERD. Misoprostol, 200 milligrams BID to counteract for the aspirin for GI irritation, which that's coming next on her medication list. Ketamine, 1 to 2 sprays nasally up to 4 times a day for migraines. Yavepti, 300 milligrams IV infusion every 2 weeks for migraines. Dicyclamine, 10 milligrams before meals and at bedtime for IBS. Hydroergotamine, 1 spray PRN migraine. Potassium supplement offsets the potassium loss from her diuretic. Provigil to keep her awake when she's on all these medications, 200 milligrams daily. Indomethacin, 75 milligrams BID for migraines. A multiple vitamin daily, every day, coated aspirin every day, albuterol as needed. And then medical marijuana several times daily for anxiety and migraines. Vitals, an exam that were pertinent parts of the exam on her first visit. She's 5'9", 277 pounds, which puts her BMI at just under 41. Blood pressure looks great. Heart rate was fine. Respiratory rate was fine. Oxygen saturations were good. She was morbidly obese, but otherwise she looked really healthy. You look at the medical history, and I'm kind of expecting this person that kind of looks terrible, but she actually looked really, if you saw her on, at the grocery store, you'd have no idea that she had all this stuff going on. She was well groomed and she was overall healthy appearing. She did get a little tearful at times when talking about kind of what she had gone through, but she was completely appropriate with good eye contact. So for those of you who don't do lifestyle medicine regularly, we invited some other folks to the talk today, to the case today. We go through kind of each of the 6 lifestyle medicine pillars. So for fingers, which is smoking, alcohol, and drug use, she had never smoked. She drinks 1 alcoholic drink once a month at the most. And drug use is only prescribed medications, but of note, she is on 4 controlled substances: morphine, ketamine, marijuana, and Provigil. So forks on the pillars is what you're eating. Her husband cooks. She has very limited cooking skills. Typically for breakfast, she's eating yogurt and a latte or some egg bites, which are some processed egg things. Lunch, cheese sandwich on white bread, maybe salad a few times a week. She snacks on protein bars, cheese, and whole grain crackers. She has some grapes. Dinner looks like meat, veggie, and starch. She is often eating while she's doing other things and doesn't really pay attention to her food. She reports that she's doing 0 to 1 fruits a day, vegetables 3 a day, although when you look at when you actually go through what she tells you she's eating, it really ends up being like 1 vegetable a day, so maybe not quite as much as she's telling you. Whole grains are 2 to 3 times a week, no beans, potatoes maybe 2 or 3 times a week, no walnuts, flax seeds, or chia seeds, so no regular omega-3 intake. Eggs 6 a week, dairy 3 to 4 servings a day, meat and fish 1 to 2 a day. Processed foods, she reported once a day, but from what she's telling you that she's eating more processed foods than that, so it's probably more like 3 a day. Oil 1 to 2 tablespoons a day. She does drink lots of water at 96 ounces, 2 cups of coffee a day for caffeine intake. Meals out or taken are about 2 to 3 a week. So I gave her an overall estimate of whole food plant-based food consumption of about 10%, which is pretty much the standard American diet. Feet. She horseback rides twice a week. So she actually has a set time, 2 days a week, where she goes and rides. So she doesn't, it's not like it's her own horse and she can ride whenever she's feeling well. She has set times when she goes. And if she isn't feeling well enough to ride, she doesn't go, and that hardly ever happens. She actually also reported that if she has a headache when she goes, she usually feels much better after she rides, so she goes anyway. She reports doing virtual reality fitness games 1 or 2 times a week. And on the days she is not horseback riding or doing virtual reality games, she's walking for 30 minutes. And pretty much she says she always does that. She gets that activity in every single day. Sleep, uses her ASV faithfully. It almost completely eliminates her sleep apnea and central apnea. She falls asleep easily and typically does not remember waking at night. She's sleeping 8.5 hours or more every night. She never feels rested. She always feels tired. Stress. Her major stresses are her extensive medical issues and keeping up with all of the stuff that she has to do with that, dealing with having chronic pain. She also has twins who are age 12. Her daughter, when I saw her the first time, was in a partial hospitalization program for anxiety and had some significant behavioral issues. Son has some cranial issues that have required several surgeries over the years, and he's not completely done with that as well. She can go into a lot of details with that. No behavioral problems, but just some surgical issues. She denied any significant financial or housing stress. Husband has a good job, supports them all, and she does not need to work. She is on permanent disability, so has a little bit of income from that. And stress management. When I have patients fill out a form on kind of how they manage their stress, and what she listed on that form was that she takes her meds, she goes to therapy, and she does EMDR, which is also done by someone else as part of a therapy program. She reported also that her husband's very emotionally supportive. When pressed on what she does on her own at the visit, she added that she will take a shower to calm down if she's really stressed. Being physically active really helps her to de-stress. She journals, and sometimes she does a sensory meditation, which she learned about in therapy, which 5 things I see, 4 things I hear, that type of meditation. And then in terms of what gives her life meaning, purpose, what she loves, and what her good relationships are, she has a wonderful relationship with her husband. She certainly loves her kids, although they are maybe not so supportive and require a fair bit of work. She loves horseback riding and photography, so she has some definite positives in her life. So I would like to stop here and really just kind of do a review of all the things that stand out to you. This is obviously not your typical lifestyle medicine patient at all. And I was a little flummoxed as she came in, and I'm like looking at this kind of like, holy moly, you got a lot going on with you that's kind of not standard. So I just wanted to make sure, you know, what all are you picking up in terms of the things that you really should be keeping in mind as you're working through a plan, a lifestyle medicine plan for this patient that's going to be really important to make sure that she's getting appropriate care.
So let's start with Dr. Grega. Let's start with Dr. Grega. Kerry, why don't you mute your microphone, please, or somebody in the audience. Dr. Grega, you're our guest panelist. Let's hear your reaction, please.
Absolutely. Well, Dr. Graff, like, wow, you know, when somebody like this walks into the office, there seems like there's so many places to start. And we all would feel, I think, very compassionate about how difficult this patient's life is at this point, and try to figure out some action steps for her. But the big overarching thing to me, I think, is her behavioral health, mental health issues, and how are those being addressed? I mean, it sounds like she's going to therapy. She has a psychiatrist and everything. But I'm really curious about the whole thing of her saying that she doesn't have bipolar disorder based on some of the medications that she's on. Now, obviously, those could be used for migraine or for depression, but interesting, the mix, the risperidol, the Abilify, some of these things. The other thing, too, is her history of anorexia nervosa when she was younger. I'd be thinking about ACEs, the adverse childhood experience sort of thing. Has that been evaluated for her? It's fabulous that she's got such a great support system with her husband. So I'd love to know more about that, like having her husband come in maybe to get a chance to see. Her husband is the one who is cooking, and is obviously being very emotionally supportive. So it seems like he would need to be part of her treatment plan. And the amount of medications that she's on at this point would be something that I would be concerned about and trying to figure out how to start to decrease them. But because she's on so many different medications that you wouldn't want to just stop, this is going to be a real motivational interviewing, shared decision-making thing with the patient about, what are the right things to start looking at decreasing, if she's even willing to do that. So I think one of my first steps would be, if at all possible, to talk to her psychiatrist or her mental health team and try to find out what's really going on with her as far as her therapy, so that can hopefully help you figure out where's the right steps to start as far as from a lifestyle medicine approach. I mean, definitely with our typical lifestyle medicine, we'd think, oh, nutrition, we could definitely work on that. We could definitely work on increasing physical activity, but to be able to set goals and achieve them, I think the behavioral health issues have to be looked into.
Thank you, Dr. Grega. Dr. Sundermann, your thoughts? And notice some furrowed brows there on the other panelists.
All right, thanks, Dr. Graff. I echo what Dr. Grega is saying, and this is definitely a challenge. And I agree with the motivational interviewing. And I think I would want to ask this patient, what are you hoping to gain, right? She went to bariatric surgery, so it's very easy to say she wants to lose weight. And then going beyond that, why do you want to lose weight? Because I want to feel better. Why do you want to feel better? Because I, want to feel more confident. Why, and going down that, what are her true values of why she even prompted her to go to bariatric surgery in the first place, just to gauge where she's at, because obviously the number on the scale seems to be important to her, but you got to peel that onion and get to these underlying reasons of, how did she end up in this place that she's at? Is she in that pre-contemplative phase or contemplative phase to even know that an awareness of all these medications? And is this just sort of her story now? And is she living this part as an illness? And I agree with Dr. Grega that I think the anorexia as a teen would be something that you might want to try to get into. Was there some kind of trauma that prompted that? Was there something going on in her life, a stressor that, had that experience? And then with the PTSD, I don't know if you got into that at all, if there was any trauma. So I think that really getting to her motivation of what her goals are as far as living a life and having vitality would then maybe lead me to next steps of how to approach connecting with her and maybe targeting more of a plan.
Thank you, Dr. Sundermann. Dr. Breakey, your thoughts, please.
I agree that we've got to find a lever here. We've got to find something that will bring her on board. In a sense, the fact that she wanted bariatric and was refused and is referred to us makes me a little nervous. It's almost kind of like the person who gets their DUI and is court referred to go to the treatment program. Well, they may or may not be that excited about doing that, but they're going to because it's a step towards what they want to do. So what is motivating her and what would help? Now, the good things are, she's smart. She's an ICU nurse. She's well kept. She wants to get better. She has some sense of of goals. Again, not like some people who just sit there with their arms folded and go, I can't do anything, don't talk to me. So she's engaged in that way. And yet patients develop different approaches or coping strategies to illness, which often are formed in childhood. And this pattern of problem, take a pill, a problem, take another pill, side effect from the pill, take another one, is very evident in her medication list of 5 or 6 or 8 different ones for migraine, without evidence for what's causing the migraines. And did we try something to figure out, stress, food intolerance, or a lack of sleep, or some reason that she developed those when she got into the ICU nursing stage. And then, oh, weight problem, bariatric surgery. It becomes sort of a reflex to say, I'm going to do it this way. And I talk to my patients and say, boy, I've got an option for it. You don't want to seem pushy, but you want to say, hey, there may be a better way, and start to feel out what will help her to see that for herself instead of me just telling her. So again, very interesting case, Dr. Graff, to bring for us. I appreciate it, and I'm interested to see how it next unfolds.
I just wanted to also say, I think that is so interesting about the horseback riding. When I was going through the slides beforehand, Dr. Graff, I'm looking at this woman on all these medications and in this chronic pain state. And I've horseback ridden, but I'm not a rider, but I'm sore the next day, right? This is a very physical, and your reaction times and your awareness, you have to be very capable. And I think that's really interesting, and something that you maybe, want to grab on is that when she feels the most alive, right? Of her true self, of when she doesn't experience pain and the stress, alleviates. And to maybe, hone in on that. It's like, wow, that's amazing that this is an outlet for you, right? That everything else disappears at that time. I think that's really interesting.
That's a great comment. Anything from the rest of the panelists before we go back to Dr. Graff? Dr. Grega, any other thoughts?
Hi, can you hear me? It's Dr. Hughes here. Hello.
Oh, hello, Dr. Hughes.
Dr. Hughes is from bariatrics, and she's the one who sent this patient down to us.
Yeah.
So thank you so
great.
much for joining us. I really appreciate it.
So
Great.
this patient came to me, and thank you for having me. I'm very excited and happy to be part of this. So thank you for sharing
great.
this opportunity with me.
Great to have you here.
Yes. So this patient originally came to me, and whenever a patient sees me for the first time, I'm glad someone brought up, I always ask what their goals are and why they want to have surgery. For this patient, she specifically said, my goals are to spend more time with my children. I want to go hiking, skiing, and actually, do more with her horse. So I think she is and feel more comfortable in her own body. So there's a lot of activities that are her goals, and family oriented, which also are important. She does have a really good support system. For many of the appointments, her husband was present and was very inquisitive. And I always ask and make sure that if they have a good support group or a good support system at home, to ensure that someone's going to be supportive and not always having junk food around the house or things like that after surgery, which it seems like she does have that. Originally, when she came to me, she had this history of migraines, and she was on indomethacin for the treatment. And then to counteract that NSAID, she was on misoprostol. The interesting from my point of view is that she has also really bad reflux. And I did a pH probe, which she had a high demester, which means she has innate high acid in her stomach, which basically means that I can't do a sleeve, which is the banana surgery. So she only could get the bypass, but you can't have a bypass and take NSAIDs. And she thought there would be no way for her to come off the indomethacin. And I said, okay, why don't you talk to your neurologist? In the meantime, I just didn't want her out floating in the world without any help, kind of in other aspects of her life. So that's when I referred her to lifestyle medicine. In the meantime, she did end up following up with her neurologist. They were able to come off of the indomethacin and the misoprostol, and now she's just on the Vyacti and the ketamine and the MS Contin. I mean, if that's enough, right, for the migraines. So we are planning on going ahead with the bypass. On one point, it's going to help her really bad acid reflux. And then on the other point, obviously weight loss. So that's kind of, the update from there. And I do agree that there's some challenges with her psych medications. And I always tell people, after a bypass, those medications can be metabolized differently and they need to be aware of any changes in their mood or anything. And her husband was aware as well to make sure those get brought up with her psychiatrist.
Right. Thank you for filling in, Dr. Hughes. I really appreciate that. I wasn't expecting, but I'm so excited you're here.
Me too.
Yeah. So the reason she was not a candidate was because of the acid reflux and the high acid.
No, she wasn't a good candidate at that time because she was on a daily NSAID to treat her migraines. And with the gastric bypass, you can't take NSAIDs because they cause ulcers.
Got it.
And a sleeve, and she has really bad acid reflux. So a sleeve, you can't you shouldn't do someone with really bad acid reflux because it'll just make the reflux worse. So I was kind of cornered and saying, okay, you can only have a gastric bypass, but you take this NSAID every day. Those two things don't complement each other. They're actually counteracting. So I said, while you work with your neurologist to come off the indomethacin, if that's possible for your migraine and maybe a different medication, I didn't want to leave her just out in the wind. So I referred her to, lifestyle medicine to help, continuing working on herself and with everything you all do, which is great, just in case she could never come off of it. I wanted her to have another option to, improve her life.
So is your plan to do some kind of anti-reflux procedure on her?
Yeah. So a gastric bypass is for weight loss and it's an anti-reflux. So it's like a double kill two birds with this one stone kind of procedure. It helps with weight loss, and then it also helps reduce acid and will greatly improve her acid reflux.
Okay. So it won't be an anti-reflux procedure per se, but it will reduce the acid?
Yeah, so it reduces acid, anti-reflux, and it's for weight loss.
Got it. Okay, thank you so much.
Yeah, and I wouldn't just do like a regular anti-reflux traditional procedure on her because those don't tend to do well with someone who has a higher BMI.
Right. Does anybody else have any questions for Dr. Hughes before we get back to Dr. Graff? Any of the panelists? All right. Thank you so much, Dr. Hughes. Back to you, Dr. Graff.
So there were, thank you, Dr. Hughes. So there were a couple of other things that kind of stood out to me when I was going through her history. She was very focused on weight loss, helping her quality of life. But the thing that has made her disabled for all this time and impacts her quality of life hugely are her migraines, right? So it was kind of like this, yes, if we could get the weight off, that would help your reflux and it might help. It just didn't seem like it was where most of the quality of life issues were coming from. Wasn't so much her weight. The PTSD, I wanted to just bring up the point that it's for women when it is a sexual assault causing PTSD, much higher risk of obesity and women who are sexually assaulted. And it's one of those issues where if you've got somebody who is obese, especially when it's a woman, and they lose 20 pounds and they're happy and they're really excited, and then it can trigger this feeling of vulnerability, and they will end up gaining the weight back as a self-protective mechanism. So when I'm seeing somebody who's overweight and they're working on weight loss, if they have any kind of history of anxiety or PTSD, if there's any kind of thing that makes me suspicious at all, I want to ask about if there's a history of a sexual assault. Obviously, you need to ask very gently, especially if you're just meeting somebody, and also why, which is, as you lose weight, if you have that in your history, it can trigger all kinds of psychological stuff that is problematic. So you want to make sure they're in really good psychiatric hands at that point. And you could just, usually when you can bring it to people's awareness, it doesn't get in the way, but it can be really problematic. And I just wanted to share that I have, since I've made that a routine part of when I'm meeting with a patient, I cannot tell you how many women have told me that I am the first person they told about the sexual assault, that it happened 20, 30 years ago, and they've never told anyone. So really important to get that out. So she was not sexually assaulted. Her childhood history of PTSD has to do with neglect from her family of origin. Obviously with anorexia, that makes you very nervous about this focus on weight versus on healthy habits, right? So she's not really that interested in kind of making the habit change. She just really wants the weight loss. So that was just something that I thought would be really important to kind of put into her plan. She had multiple severe adverse reactions from medical interventions. She had that occipital nerve stimulator that got infected and had to be removed. She's had 2 DVTs from her PICC lines. She had that migrated port that caused an MI. You know, like she has like major bad things happen with interventions, and yet she keeps coming back for more, right? So that makes me a little bit nervous about the bariatric surgery as well. The massive polypharmacy is obviously very, you know, she's on 8 different medications for migraines, 8, 5 for depression, 4 for GI, and then she's on multiple prescriptions to counteract the side effects from her other meds, and 4 controlled substances. So just, you know, pretty amazing amount of stuff. And being on the Provigil to kind of counteract all the narcotics. Seriously, if you were taking all of that medication, how would you stay awake, let alone on a horse? And I think that kind of brings up kind of the thing that was most, and you're not seeing her, so it may be a little bit harder to grasp, but what she's saying about kind of what her symptoms are and how she looks just don't jive. It just is really kind of a striking difference between like how severely ill she looks on paper and what she looks like. And I just couldn't really kind of get over the fact that with how horrible her migraines are, that she can ride horses regularly. And that actually, and if you've ever had a bad headache or if you've ever had a migraine, the idea of getting on a horse and having that horse moving up and down as you're, you know, I just can't imagine what that would feel like with migraine. And yet for her, she says that she feels better when she does it. It makes me wonder how much of her migraines are really psychologically induced and not true migraines. And that makes me very nervous because of all of the stuff on her is kind of driven from a psych standpoint. You know, is this Munchausen's, right? Is this somebody who's kind of using her medical stuff to get attention that she, and this is playing out from childhood. So I know she gets the psychiatric evaluation as part of the bariatrics, but I would just want to be sure she's got a really, really, really good psychiatric assessment here, that we're not kind of chasing somebody who's got Munchausen's, because if she does, then that's going to be kind of a disaster, because she's going to have like every side effect and every complication possible with her bariatric surgery as well, because that's what happens, right, for folks that get care. Mm-hmm. So all right, so I think that was kind of it on the issue. Oh, one more thing about the Munchausen's, and if you think back to med school, right, the classic case that they will give you for Munchausen's, somebody who has a history of childhood neglect and works in a medical field, particularly nursing, in an ICU or an emergency department setting. So it just makes me very worried about that part. All right, so what did we come up with for the next plan? Let me move through here, and I gotta get rid of this because it's in the way. Okay, so what I gave her at the first visit was I encouraged her to ignore the weight because I didn't want to trigger stuff that was going on with anorexia and this, you know, hyper focusing on weight, focusing on improving the habits that were causing the weight instead, and let the weight take care of itself as she fixed her habits. I strongly encouraged her to keep her appointment with the sleep clinic. She had one coming up in the next couple of weeks to confirm that the sleep apnea is being well treated and, you know, that she's adequately managed there and that she's getting into restful stages of sleep. She should go for that. And I asked her to talk to psychiatrists. She had an appointment coming up with them as well within a couple of weeks, about whether she really needs the Risperdal, because that's going to make it incredibly hard for her to lose weight when you're on those kind of medications. And I did not see a need for her to be on it from her history, but Obviously, there may be something that I don't know there, but I put that, I kind of like the top of her to-do list really was to keep that appointment with the sleep clinic and make sure she talks to psychiatry about the Risperdal. I wanted her to start building a stress management maintenance plan stuff to do all the time to kind of help her be more in control of the stressors that she's got instead of just using an emergency plan, which was what she was doing, right? She kind of turned to things when she was already anxious, but she didn't have any kind of plan to kind of keep herself from being so anxious. So I asked her to do no electronics in the first hour of the day. Pretty much as soon as she wakes up, she goes on her phone and she starts doing electronic, she's looking at Facebook or she's doing, looking at news. Take the first 10 minutes in the morning to just settle into being a human being before becoming a human doing, just really kind of focusing on who she is as a person. And then making sure that she also takes some time in the evenings, no electronics after 9:30 at night, journaling before bedtime, 3 good things from her day and why they were good. And then to get outside for 10 minutes minimum every day. From a fork standpoint, I asked her to only eat while sitting down and actually paying attention to her food. No, watching TV or scrolling on the phone or anything like that, to really focus on that because she did a lot of mindless eating. To avoid all dairy and especially cheese, kind of talking about it's big like Miracle Grow for weight gain. Work on finding a plant-based milk substitute that she liked for coffee. Try a plant-based yogurt to see what kind you might like, and try to increase to 3 fruits a day, 1 at breakfast, 1 at lunch, and 1 for a snack between lunch and dinner. So I didn't give her a whole lot, I'm not pushing like this massive whole food plant-based kind of thing, not going too crazy. She doesn't have any cooking skills. Let's get some stress management stuff. Let's get her kind of paying attention to her food, and let's make some small changes that might be helpful here. Hoping for, some early wins that doesn't require a whole lot of effort. And then I was going to see her again in 4 weeks to see how things were going. And always reminded this is a no flogging.
Dr. Graff, before you go to the next slide.
Yes.
Dr. Grega, would you like to comment on the plan?
So I think that this was a great way to start, Dr. Graff, because like you gave very concrete things that you can say whether or not that she followed through or not. So like you said, early wins, don't try to change everything all at once. I agree with some of the things that are kind of coming up in the chat about how can we manage more of the psych meds that might be causing weight gain. And yes, MS Contin is definitely not recommended for migraine, and neurology white papers and neurologists in general aren't thrilled with narcotics as a way to manage migraine. Unfortunately, she kind of came to you with all of these habits already entrenched. And so it looked like what you started with was gentle things that could make a big difference, but sort of get her in the right direction to have a couple of wins. The only other thing that I would think about, and I think that I'm sure it was something that you've maybe connected with her about as well, is getting her husband involved in this plan so that she would also maybe have some accountability of somebody else who was like, hey, so what fruit did you have for lunch? Or the things that you might be, hey, what sort of yogurt did you try? Just to have somebody who's the buddy, because you can't be there all the time to check it out. But I love how you gave very, very specific small baby steps to start getting her in the right direction.
Thank you. Dr. Sundermann, any thoughts?
So going back to what you're saying, Kerry, about secondary gain, and I think it's really interesting to look at this pattern of there was maybe some neglect as a child, and now she's in a very supportive marriage, right? So her being sickly and needing this care, and this is part of her identity now, right? So she does a lot of visits, doctor's visits. She has a lot of medication. She needs a lot of care, and she has this husband that's been wonderfully supportive, goes to appointments. And then interestingly enough, she then can be the non-neglectful parent taking care of some children with ailments, right? So it's kind of like this, someone is now taking care of her, and then she can feel maybe validated by both of her children, or have some struggles as well. So I think that's a really interesting dynamic. And, part of her love from her husband might stem from that, she needs to have these needs in order to keep, getting this love from him. So that's just an interesting perspective to think about. I agree with Dr. Grega and how you approach this, of just these small wins. And I'm wondering if sometimes I'll, ask the confidence scale of like, hey, how about this? Or on a confidence scale, are you from 0 to 10, where are you? And then, really we want to go after a 7 or above. Do you feel like you can switch from a dairy milk to a plant-based milk? Oh yeah, that's an easy one. I'm a 9 at that. Okay, that's a great one. So I think that's something that I like to, when I come up with some ideas, I like to talk to my patients and use that confidence scale so that we're not going after something that they're like, yeah, I'm about a 3, because they're probably not gonna be able to do that. And we want, like Dr. Grega was saying, those easy wins.
Yeah, these were all negotiated. So the patient
Okay.
said yes to all of these.
Yeah.
She was okay about I will try to avoid all dairy. I will certainly work on avoiding cheese, so these were all things that she said she thought that she could do, at least mostly.
Okay.
Yeah. And a good idea not to start with, hey, I think we should decrease your MS Contin, right? Because that probably would not have been the best way to start the win. But in the chat, there was a comment about dairy and migraines. And I agree that would be a great one to just highlight for the patient of like, maybe that's one of the triggers, because I think you mentioned, Dr. Graff, that they hadn't really looked for what were the triggers of the migraines, and now she was having them every day.
Yeah, I actually don't know if they look for triggers for the migraines. She'd had them for a long time. I don't know whether it was actually investigated at all. So
Her triggers are actually sugar substitutes like Splenda and all like the fake sugars that go into like the diet, like those diet foods with all like the substitute sugars. Those are one of her triggers.
yeah, but she's avoiding all of those already though, and she's still having horrible migraines apparently, right? So
right.
Obviously there's other things definitely that are causing a problem here, or is this not really as severe as what she's saying, is the other question.
Interesting. Thank you. Dr. Breakey.
I like in your plan here, you've got some things to cut back and some things to add. It's always good to give both sides of that. And I understand why you picked the dairy as a kind of #1 area. At the same time, this might be one of the bigger challenges for her, because we know that she's got, her brain is wired towards reward system, towards dopamine, with 4 controlled substances, with the kind of sense that I'm going to fix this with meds, with an inability really to do this on her own, in spite of a good knowledge. I mean, she's a nurse, she knows better, but that means there's an inner kind of dependence disorder in there that is craving certain things. And we now know that foods are also in many ways triggering the same kind of addictive patterns in the brain with dopamine, with the reward centers that then send messages to the hippocampus. And the 4 main things that our brains look for are calorie density, because our ancestors lived in times of starvation; salt, because they didn't have much salt in their no processed foods unless they lived by the ocean; sugar, because fruits were adaptive and healthy; and then things that other substances that would naturally occur in foods. But in her case, the dairy has all of that. And that #4 category, we now know that the casein in dairy products metabolizes to casomorphine. So you've picked probably the #1 most important food group from a lifestyle medicine approach with respect to migraines, her weight concern, et cetera. And yet
The hardest one for her to get rid of.
It may be one of the hardest because of inner self that we also need to deal with. So I don't know, it's an observation that sometimes we say, I know what's going to fix you best and fastest. This food that's intended for baby cows is toxic to you and you got to get rid of it. And suddenly they're sitting back like, whoa, I give up anything but my cheese. And Dr. Barnard's book, The Cheese Trap, was a good one on this. But we now know that because of that may be a greater challenge for her. So if you're trying to bring her baby steps, maybe start with the chicken.
All right. Thank you for that. Dr. Graff, would you like to proceed, please?
Sure. All right. So 4 weeks later, she did not come to the office on her follow-up visit. It was a video visit follow-up. She reports that she did go to the sleep clinic, but they wanted to talk to psych, and she hadn't heard back about a plan for any further testing, whether she needed to get re-sleep tested or anything. She was frustrated that she had lost only 6 pounds in 4 weeks. when she has at least 100 pounds to lose and how long it was going to take at that rate to lose the 100 pounds. She reports that she asked to be reconsidered for gastric surgery, or was being reconsidered for gastric surgery. So kind of back on the, like, I might be actually able to get it. Whereas at the first appointment, how it was presented to me, and I think how she interpreted it at the time, was that she wasn't going to be a candidate, period. At the follow-up appointment, she was like, well, maybe I can. And she was working on getting off the NSAIDs at that point. And then she appeared bored at that visit and didn't have very good eye contact. On the other hand, on a video visit, it's harder to connect with folks. So, but she definitely wasn't as engaged as she had been at the first appointment. So follow up on the initial lifestyle medicine plan. So focusing on the ignoring weight and improving habits instead, she totally was not doing that. She was totally focused on the weight, being very upset about only losing 6 pounds in 4 weeks. She did keep her appointment with the sleep clinic, but we didn't have a plan yet. And then she stated that she forgot to talk to psychiatry about whether she really needed to be on the Risperdal, which was kind of odd because it was right at the top of her list in terms of a medication really impacting weight gain and that she might not need it. So that was a bit, I didn't quite understand why she would have forgotten that one, because I had really stressed it at the first appointment. Working on building the stress management plan, basically she made almost no progress here. She was using electronics most of the time, at least half the time in the morning. She was not taking 10 minutes to just kind of be a person before she started doing things in the morning. She was still using electronics at night. She journaled her 3 good things from the day and why a couple of times over those 4 weeks, like 3. And then 10 minutes minimum outside every day. She was doing that more than half the time, but that was about what she was doing previously. So that actually didn't increase at all. So in terms of kind of increasing her management maintenance plan, really got kind of nowhere with that. Only eating while sitting down, she was not doing that at all. But she said she was actually trying to pay more attention while she was still, scrolling on her phone and watching TV while she was eating. She did cut back on the cheese. She was, down to 1 or 2 servings a day, but had made some progress. She did find a plant-based milk she liked for a coffee. She was using oat milk. She did try a plant-based yogurt she did not try a plant-based yogurt. And in terms of increasing fruits, she was doing more, but it was still usually 1 a day and sometimes 2. So she didn't increase it by much. It had been 1 a day. So follow up on fingers, nothing had changed there. Following up on the forks, some improvements, right? A little bit more fruit, a little bit more whole grains, a little bit more potatoes in her diet, a little less dairy, and overall whole food plant-based percent went from about 10% to about 25% by my rough estimate. Follow-up on feet was really the same, except she was doing some downhill skiing now. So she would substitute that out for virtual reality games. So really about the same level of physical activity, but downhill skiing is as part of that. Sleep had not changed. And then stress management, we talked about that already, that she did not really make much change in that at all. And on the love pillar, that had really not changed at all. So the next lifestyle medicine plan at the end of the second visit was about keeping mindful about food and avoid distractions while eating. To go ahead and, so I always put the things on that they didn't do the last time, if they're willing, right? Is this something that you're willing to do and just haven't gotten to yet, or do you want to like nix this one? So she said yes. And so we put a bunch of the things back in that she hadn't done from the first one. So the 10 minutes outside every day, 10 minutes to settle into being you in the morning, and the plant-based yogurts went on the yes, I will do that list. We talked about making a big pot of vegetable-based soup on the weekends for lunches during the week, trying to get more vegetables in. And we were specifically talking about working with her husband. So she actually does have some skills in the kitchen, but they mostly involve kind of prepping things that her husband would then cook. So in trying to get him more on board with things, I asked whether she thought she could kind of, pick a vegetable-based soup with him and then, kind of making it together. I was also thinking, if this is an attention-getting thing from being sick, well, it could be something where she's getting attention because they're doing this healthy food together. And it might be a way of kind of moving from that sick mentality to doing healthy things together mentality. And then making sure every meal has a whole grain bean or a potato in it to make sure she's feeling full and satisfied. And I think that was it for that. Oh, we're talking about batch baking sweet potatoes to use as desired during the week. So easy enough to do, and she can just reach them out and grab them if she's hungry. Not getting more than a 7 out of 10 on the hunger scale, so she doesn't end up super craving the high calorie dense foods. Keep reducing the dairy as much as possible. Trying to do a salad as first course at dinner because she actually does eat salad, but kind of thinking that as first course because it's something that's easy for her to make as part of it as well, and front loading with the lower calorie density foods. We talked about dressings that we could use, although I was worried they might be a little problematic with her reflux. Doubling up on her vegetables at dinner with a plan to recheck in 6 weeks. So I would love to hear now what anybody else would have done with that plan, what you would have done differently than what I picked.
Dr. Grega.
So Dr. Graff, I feel like this actually has been working, and it just doesn't seem like that she's feeling that it's going fast enough, like you said, and it's that managing expectation thing for patients, that the fact that she lost 6 pounds in 4 weeks is kind of in line with what we would have expected with what she's doing.
And
so
perfect, right? It's like the perfect amount of weight loss, because if you lose it too fast, then you get the metabolism, slowing down issues. So like I was super happy with her weight loss, and yet she's completely unhappy and unsatisfied with it.
Yeah, and that's a hard discussion to have, absolutely, with patients, and everybody wants the miracle fix kind of thing, but that's part of what, and I'm sure you did this, is I would have really reinforced to her, like, wow, this is awesome. I think you're doing a really great job. You've lost 6 pounds, you've made some progress, you've gone from the 10% whole food plant-based to 25%, and in general, it's unusual for a patient to do everything right the first time that you give them as a kind of lifestyle prescription. So focusing on the ones that went really well. I'm glad that you talked to her about, for the ones that she didn't do, is that because she really doesn't want to do them, and then you just want to get rid of that and move on to something else? Or was that she was just not ready to focus on them? But the thing that I love the most is that you talked about doing the cooking with her husband, because I think that doing that type of preparing whole food, plant-based, kind of like a low calorie density, high nutrient density food that they do together that's really easy to grab, is an excellent lifestyle medicine prescription for this patient. Now, if she's not going to find that as a fulfilling time with her husband, like you had said, if she's looking for the attention or the caregiving, maybe it won't work as well. But the idea is a great one to try. And the way that you have structured all this, what she should eat first with her meals, is also, I think, an excellent way to shift her calorie density to the point where she'll be feeling more full. And even though she might still be having some of the meat or the dairy, she won't be eating as many calories. So the biggest issue, I think, here is, do we really think that she has engagement? Because what you were saying about the way she was acting during the video visit, all of these recommendations would put her right on track for the weight loss that she's looking for. Now, definitely the psychiatry and trying to figure out what's going on with her meds is another thing that I would think of as a really, really high priority. I don't know if you could have asked for permission or tried to get in touch with the psychiatrist yourself to try to figure out what is going on here, because there seems to be a disconnect with what you're hearing from the patient versus what might be the best approach to at least talk about with psychiatry. Possibly increasing some exercise would be the one other thing I would think about, but at this point, you're not even sure if she's ready to do the things that you're asking her to do. So I think it's important not to overwhelm people in the beginning. So I think that you are on the right path. And the only thing I would add is considering getting in touch with psychiatry to try to find out what's going on.
All right, great comments. By the way, so we are running out of time. And what I'm going to do here is make a couple of announcements, and then we'll come back to the discussion. So I know, Kerry, you have 2 more slides. So Kerry, if you could just unshare for just a minute, please.
I can.
All right, great. And I'm gonna share, whoops. Let's see. I think I can do that one. Whoops, here we go. Okay. Is that showing up?
Yes.
You guys see up? You see upcoming events? Great. Okay, thanks. So first of all, I just want to remind everybody that as soon as this is over, you're going to receive an email or with a link to a survey. And if you fill out the survey and get to the end, you will receive your CME credit for an hour for participating tonight. And we're thrilled that you can do that. That's a and then the next Lifestyles Medicine lecture series, Dr. Liana Leonoff will be talking about strengths in the mirror, thriving now and tomorrow. Dr. Liana Leonoff is a pioneer in the lifestyle medicine movement. She was former president of American College of Lifestyle Medicine. And April 12th, we'll have lifestyle medicine grand rounds just like this with Dr. Osfeld, a cardiologist in New York City, and who is our guest panelist, and Dr. Robert Black, who will be discussing a cardiology patient case. And I'm going to stop sharing now. And Dr. Grega, you've got an announcement to make about ACLM, please.
Just very quickly, for this year's Lifestyle Medicine 2022, the ACLM Annual Conference registration is now open. You can go to lmconference.org. And we just want to throw that out there because we are capping attendance in person at 1,900 people this year. I'd love to see all of you guys there. So we feel it'll probably sell out sometime by the summertime. So put it on your calendar to take a look at the registration for Lifestyle Medicine 2022, November 13th through 16th down in Orlando, Florida.
Yeah, should be great. We'll send a link out to that as well. Wonderful conference. We just love that conference. So Dr. Graff, do you want to share your last two slides with us, please?
Will do. For some reason it went all the way back to the beginning, so let me fix that. Oh, there we go. All right, so I just wanted to read kind of what I had written specifically in my notes. Patient remains appropriate for lifestyle medicine intervention, although it's unclear how motivated she is at this time. She didn't follow through on about half of the initial lifestyle medicine plan, even though we picked items that were relatively modest and did not discuss possibly discontinuing resveratrol with psych, despite that being a high priority item on her lifestyle medicine plan. She plans to move ahead with bariatric surgery if she is deemed eligible, even though she's losing more than a pound a week, despite having only made minimal changes so far. I'm concerned about her possibly having a learned helplessness mindset, or there may be an element of secondary gain that may interfere with her ability to make lifestyle change. In any case, a new lifestyle medicine plan was made, and we will see if we make any progress in the next 6 weeks. And then she didn't make a follow-up appointment, and she's scheduled for bariatric surgery next month. So, so kind of my epic lifestyle medicine fail. I didn't get her engaged in terms of making more lifestyle changes here, but she is going for bariatric surgery. So,
but Dr. Graff, that's not an epic lifestyle medicine fail, though. You've taught her all sorts of things that she's going to need to utilize after the bariatric surgery. So,
well, I mean, except the diet,
that weight loss is possible, that food choices make that much of a difference. So I know it's hard when people, when this happens, but I would say you definitely didn't fail. You started the beginning of the journey. The lifestyle medicine journey for this patient is just beginning.
Well, you know, the bariatric diet, the post-op bariatric diet is so different from what I had been recommending that she do, right? So she's going to be going protein first, right? And basically avoiding all of those foods that tend to take up a lot of space and don't have a lot of calories, right? Initially.
But your stress reduction stuff, oh, sorry guys, your stress reduction stuff will be very helpful.
Yeah, you planted a lot of great seeds for her, and that's what will come back to help in her recovery phase from surgery and for the long term. I mean, we all know that even if she had done everything you said, the challenge is ability, and getting those seeds planted now while she's in a teachable moment is much more important than all the rest put together. Also recommend Dr. Garth Davis's book, Proteinaholic, by surgeon. And for those who haven't read it, he's a bariatric surgeon from Texas who really puts it out there about how the worshiping protein has become a part of our problem.
Mm-hmm. Right.
And I agree. I think, Kerry, you did a fabulous job, and I learned some pointers to take and from your case. So thank you. And you took this patient, Rebecca, from a pre-contemplative stage to a contemplative and to even some action steps. So you have moved her along that spectrum, right? And planted those seeds. I think this case also shows us the need for health coaches and group support. And because this is a lot, you know, we see, and we're kind of structured the same way. We do a lifestyle medicine consult, and then it's 4 weeks later that we see them back. So that's a lot of time that they're on their own, having to motivate themselves and learn. And so, you know, we utilize Ted's 15-day jumpstart program a lot of times because they get that group support, they get that education, they get some hand holding. Because it's a lot, you know, to go home and then figure out how to do this. And I don't see my doctor back for 4 weeks. So, you know, the team and you know, we could all use more help. And I know we're as physicians trying to manage this all ourselves. And so perhaps, you know, if she had a little bit more support in between seeing you, that could have helped, you know, carry her along a little bit.
Yeah, thank you. By the way, Kerry, I'm going to make an executive decision. If you could unshare your screen, I would love it if Dr. Hughes could appear magically by unmuting her video, and maybe Bob can even greenlight her. I'm not sure. Spotlight her. But anyway, I'd like to thank the panelists so much. Dr. Grega, our guest panelist, I thought you were brilliant. Dr. Graff, you were amazing. And I know you made a little self-deprecating remark at the end, and everybody jumped on to compliment you and say, "Don't worry, you did a great job. You did a great job." And I would have to agree. It's a fascinating case. Oh, and there's Dr. Hughes. Dr. Hughes, thank you so much for joining us.
Yeah.
Dr. Hughes, do you have any final comments?
I think this has been a great opportunity to see how lifestyle medicine and the bariatrics can actually come together to help a patient. I think that's important that if we kind of share, like she was talking about, what our post bariatric diet looks like, and then over time, like at 1 year, you know, after, they're often eating, depending on what kind of surgery they have, you know, higher protein, but it's still important to understand how to make a plate. So, and what to eat. And it's not just about protein, but also, like you said, greens, getting rid of, and learning plant-based protein as well. So I don't think that lifestyle medicine should, you know, those appointments should just go away after bariatric surgery. That just enhances the patient's recovery, like you said, weight loss and their process. And I look forward to working, you know, with the lifestyle medicine, you know, group more and collaborating. I think I didn't even pick up on the Munchausen's, but I think that would be something that, you know, I'll talk to Dr. Graff about, you know, what do we do about that? Interesting, something that are, you know, might be adding to it is that her husband's father is actually a doctor. So the husband is like pseudo Dr. Google, but knows a lot of things. So I don't know if that would like feed into it or not. But yeah,
you know, I don't know her well enough to know if that's really what's happening with her, but I'm worried because if that is what's happening, and this is all secondary gain, she's going to have nothing but horrible things happen after bariatrics, which you're going to have every side effect, every problem you could possibly have, he's going to have it. Right. So when she was going back, I was like, oh boy, like I was really debating, what do I do? Do I write you a letter kind of saying, these are my concerns about this patient? I know she's seen psychiatry, but I'm like, I don't know. So then I was like, well, let's see if she wants to come to Grand Rounds and kind of like listen to like,
for sure.
So, you know,
I will definitely be talking more.
So now you don't, Kerry, now you don't have to write the letter.
Right. And I'm like, I was feeling like, is this like, you know, I wasn't sure why I was getting out of bounds with kind of contacting you kind of behind the scenes that she's kind of going back to bariatrics and saying, oh, I'm really worried that there's something going on when she's already seen psych. Right. But I don't know. There are just a lot of red flags here.
Right. And you and I should talk, like we should, I'll email you and we'll talk more to figure out how, you know, I don't think she's not a candidate for surgery, but I think there's definitely some things that need to be worked out regarding her psych meds and then, you know, looking into her neurology more or something. So you and I will have to kind of talk to figure out how to, you know, kind of detective work this out, I guess.
Yeah, this is a lot of
great case
stuff
to come back in a year. So like if you guys can bring the case back in a year, this would be awesome. See how she's doing.
Great idea. We would love that. Yeah. So yeah, thank you. And it's we've run over quite a bit. So, but I'm glad we were able to do that because this was really important. So thank you all. I hope to see you next month at our next Lifestyle Medicine Grand Rounds. And you'll be getting an email shortly reminding you about how to get your CME. So again, thank Dr. Breakey and Dr. Sundermann, Dr. Grega, Dr. Graff. Thank you all so much. And see you around the playground. Good night, everybody.
Ted.
Nice.
Good
Thanks,
night.
Ted.
Thank you.
Everyone.
Thanks, everyone.
Bye.
All right.
Thank you.